Okay, and a very good morning to all of you. Thank you so much for joining us for our SUD treatment learning community. We are delighted that you can make it today. We thank you for taking part and joining us. The subject for today's community of practice is emotional attachment behavior therapy. And this community of practice is being sponsored by the New Hampshire Department of Health and Human Services, as well as the New Hampshire Technical Assistance Centre. So just before we go ahead and get stuck in here, we'll take care of a couple of points of housekeeping. So firstly, we are recording today's meeting, so there are a couple of things to consider. We would like to ask you to keep your microphone on mute at all times, unless you are actively speaking, and that helps us produce a good recording. We do publish recordings of these meetings on our website, and so we welcome you to put your camera on at the same time if you would prefer not to appear on camera. We completely respect that. And we'd also ask that you don't share any personal information that you wouldn't want posted on our website later. Point here about your microphone as well. If you're having any issues, any connectivity issues, maybe struggling to hear, you can always go ahead and maybe try switching your camera off, maybe try a different audio device. You'll find that on the bottom left-hand corner of your Zoom screen next to audio, you have a little arrow, and that should allow you to select a different speaker or a different microphone. We appreciate your engagement very much. We do appreciate that this is a community and your input is valuable to us. So feel free to go ahead and share a reaction using one of the emoticons in the reactions tools. Maybe you want to type something in the chat, or perhaps you want to raise your hand so that you can say something. All of those features are very welcome here, and we actively encourage your engagement. So just to discuss the meeting objectives a little bit, what we've got to look forward to. The first meeting objective is to understand how research demonstrates that attachment disorder correlates with behavioral health issues. Second objective is to evaluate how attachment stresses can exacerbate thoughts, feelings, and behaviors that increase unhealthy outcomes. And thirdly, interpret how a patient client can increase awareness and coping skills around their attachment stresses, increasing positive outcomes. So with that, I would love to go ahead and hand off to Melissa. Melissa, it's all yours. And Melissa, are you there?
Stephen, it looks like Melissa might be still connecting to audio. I can go ahead and read the bio if that's all
Yeah,
right.
would you? Thank you,
Um,
Paul. Thanks.
yeah, absolutely. Well, thanks for joining us, everyone. I'll introduce our speaker today, Doug Smith. He's the founder and developer of Innovative Realities. Doug Smith has 20 years of experience working in behavioral health services, including serving as the direct clinician, clinical director, and director of clinical development. He has a BS in psychology from Eastern Oregon University and is a certified alcohol and drug counselor level 2. Doug has innovated many modern approaches to treatment services, including developing new patient-centered treatment models. He developed the emotional attachment behavioral therapy, or EABT, model and speaks nationally to professionals in the field about its positive outcomes. Doug is the recipient of the Oregon Association of Addiction Professionals 2023 Innovator of the Year Award, as well as the 2018 Addiction Professional of the Year Community Service Award. So with that, we'll let Doug take it away.
Great, thank you. Can you guys hear me all right?
We can hear you perfectly, Doug.
Great, thanks, Stephen. Well, first off, I just want to thank Growth Partners for hosting this event, and Melissa and Paul and Stephen for all of your help in coordinating this. And I also want to thank all of you who are here joining us this morning. I know how busy our schedules can be right now with everything, and I appreciate the fact that you're taking time out of your busy schedules to to learn more about this model that I'm really passionate about. I also would say, as we're doing this presentation, as I'm going through this, please don't hesitate to raise your hand, like Stephen said, so that I can answer any questions that you have that come up along the way. These presentations are always better the more involvement from the participants, so I definitely welcome that. All right, well, to start with, talking a little bit about this model and how it came about for me. As Paul said, I have worked in the field for over 20 years in behavioral health services. I also don't mind sharing with all of you. I've got lived experience when it comes to recovery. I have been in long-term recovery for 24 years now. I also grew up in a household with alcoholism that was prevalent in the household. So I've had the unique perspective throughout my life of getting to see what it's like from the family's perspective, from a child's perspective, also what it's like for the individual going through substance use disorder and trying to get clean and sober, and from working professionally directly with clients in one form or another for a long period of time, what that process is like for people attempting to get sober. So it's offered me some unique perspectives on what it takes for people that are struggling with substance use disorder. One of the things I have found in my time, excuse me, is that connections is a really important part of the treatment process for people. One of the things I know from going through my own addiction issues is over the course of my substance use disorder, my world got smaller and smaller and smaller over time. And all the connections that I valued in my life started to disappear. My connections to my family, my connections to my interests or my friends. And ultimately my connection within myself, I felt less connected to myself, and our world just keeps getting smaller and smaller. And being a direct clinician who's worked with clients both in individual and group settings, one of the things I found working with clients is the faster I can develop connections with them, the better their success rates are. And that's something that's been shown through research as well. Being a group facilitator for a lot of years, one of the things I would try to do is as soon as someone came into the group, I would be really focused on how to create connections between them and their group members as quickly as possible. And a lot of those would be emotional type of connections. And the faster that I did that in a safe way, the better their success rates would be. So that definitely was a big motivating factor for me in developing this model. I don't know how many of you have seen the Johann Hari TED Talk, but it's something I really like. And he talks in that TED Talk about the opposite of addiction isn't sobriety, it's connection. And that really hit home with me. That's something that I've believed throughout my entire career. I'll also let you guys know I'm going to share my experiences with you. I'm going to share some of my thoughts and opinions with you. You may not agree with all of them, but I'll definitely share some of what my experiences are. That doesn't mean they're necessarily right or wrong. It's just kind of my perspective on things. One of my frustrations being in the field for 20 years is at times I have felt like as a industry, we can get stuck in our ways and kind of doing things the same old ways and not adapting fast enough. I was at a conference a few years ago, and the CEO of Hazelden, Dr. Joseph Lee, who is a really sharp guy, he was speaking at that conference, and he said, at that conference, he said one of the biggest strengths of our industry is all the people working in our industry who have lived experiences. And he talked about the reason that's such a strength is so many of them can, relate and connect with the clients in a different way. And then he turned around and said one of the biggest weaknesses in our industry is all the people that are working in it with lived experiences. And I thought that was an interesting way of looking at it. And the reason he said that was the case is he said that at times people with lived experiences can feel like they're empathizing with a client when really they're projecting their own story onto them. They're relating to them instead of empathizing with them. And he said, if I'm relating to a client, what that means is I'm connecting my story to yours, which means I'm going to think I have your answers for you. And he said, empathy is about walking alongside you, knowing that I don't have your answers, but helping you find your own answers. And I really found that interesting, that being someone in long-term recovery, it really got me to look at, where at times I'm relating to clients instead of empathizing with clients, and how to challenge my own thinking. And that's something I love to do, is like look at how I can continue to expand my thinking and challenge my thinking on some of this stuff. One of the things that has at times bothered me in my work with clients, I think the world of evidence-based practices like CBT, DBT, motivational interviewing, 12-step facilitation, I've used all of these and they're extremely helpful, and they've made a huge impact on the clients that we're working with. But one of the things that at times has been bothersome to me is I feel like some of these models address immediate behavioral issues that are impacting the individual, but they don't necessarily get down into the root issues that may have fed into creating those behaviors in the first place. And so it was really important to me when I was working on developing this model that I worked on something that not only addressed immediate behavioral issues, but looked at a safe way to start to get down into the core issues that led to that stuff in the first place. I'm somebody, as a group counselor, quite often as a group counselor, I would always refer patients for one-on-one mental health therapy at the same time, because I believe that if they're doing group counseling and getting individual therapy at the same time, that's the best of both worlds, and they quite often, that gives them the best chances of success. But one of the downsides with one-on-one therapy is when they're only meeting once a week, it can quite often take a while for the work to start to develop. And in that time, they can end up relapsing because they haven't dealt with any of their root stuff quickly enough, and one of the things I love about this model is at times mental health therapists in my area who have people who've used this model, they tell me that people walking into their office are farther along in that process so that they can start doing deeper work with them, which is really rewarding. That's something that I wanted to hear. So when I was developing this model, I really wanted it to be a three-prong effect where it addresses immediate behaviors, it finds a safe way to work on core issues for people, and then the third part of the three-prong effect is I wanted something that was at the same time improving their life and their relationships. I've seen a lot of people get sober, do a lot of work to get their lives turned around, but their lives aren't getting better quickly enough. And I'm a big believer, if we take something negative out of somebody's life and don't replace it fast enough with something positive, we leave that void open for the negative to fall right back into place. So that's kind of the way that I wanted this three-prong effect to work, and it'll make sense as I go through and explain the model to you. Another area I'll just mention briefly is um, a lot of these models like DBT, CBT, 12-step facilitation, they do a great job of working on cognitive processes, on behavioral issues, things like that. But at times I felt like they weren't emotion focused enough. And I remember at times, and once again, this is just my experience, but I remember at times as a young counselor being told by my supervisors, that these guys' feelings aren't what's important. It's their thinking and their behaviors. That's what we can change. But from being somebody in long-term recovery who's gone through a substance use disorder, feelings were a really big part of what I was doing. I was using not to feel, and I was using to feel. Like, those were two of the main reasons that I was using. So I really liked stuff that had more of an emotional focus to it. And you'll probably notice as we go through this, you'll see some correlations between what I present and emotionally focused therapy by Sue Johnson, who just actually passed away in the last month, which is really sad. But yeah, there's definitely some correlations between this model and EFT in that regard. I also wanted to create something that's very self-directed and empowering. I don't know about you all's experience, but one of the things I've seen is that, over the last 20 years, obviously the clients coming in are changing, and at times it feels like they're changing pretty rapidly, and we're having difficulty keeping up with them in some ways. And one of the ways I see clients changing as they're coming in is they're less receptive to models that encourage powerlessness, and that they're more into being empowered than disempowered. And once again, I just want, to say to you guys that being someone in long-term recovery, 12 steps is an important part of my life and my journey, and I think the world of it. That being said, the people coming in nowadays seem less receptive to some of those concepts. And so it's important that we're adjusting some of that and looking at how to work with them. And so I really wanted to design a model that could take them where they wanted to go, and it empowers them, and it feels like they're driving the car the whole way, and the counselor's just walking alongside them and creating an environment that's safe for them to do that type of work. Um, uh, I also, being a counselor at heart, and considering the fact that, I've been a clinician for a lot of years, this curriculum was created by a counselor for counselors. So the workbook is just nothing but exercises. And you'll notice in this presentation, there's not a lot of theoretical principles I'm going to show you. It's more like exercises and hands-on tools that you can utilize, because that's the way my brain works. Like I want to create stuff that clients can use and be effective. And I tried to create something that's flexible enough that it's not so concrete and scripted that it can only be used one way. I wanted something that the client can go different directions with, and the clinician can take it different directions, and that there's flexibility in that regard. So when I rolled, I was the clinical director at a large organization out here in Oregon. And when I created this model back in 2021, I don't know about all of you, but when I create stuff and it's got a big sense of myself engaged in it, there can be some insecurities that come up where it's like, is this even going to work? And are people going to like this? And one of the things I found, I was stunned that when we rolled it out at the residential treatment center that I was the clinical director for, clients filled the group up super quick. And we gave them a choice between this new model, and there was also groups that were DBT focused, CBT focused, 12-step facilitation focused. The first EABT group filled up so quickly that we had to open a second group and then a third group within a short period of time. And I think a lot of the clients that I spoke to, the common things I heard is they were really excited to have something new, because they felt like they'd been working with a lot of the same models for a long time. They also were really excited to have something that was focused on attachment and relationships. And so those were some of the big draws for clients towards this. And I'll share with you later as we go through some of the presentation and stuff that not only were clients very interested in utilizing this model, but when we started to see the data come back of comparing the statistics of these groups versus the other evidence-based practice groups, it was pretty positive early results in terms of how this model, the effectiveness was with the clients that it was working with. All right. Well, Stephen, could you open the slides for me? Thanks for taking time, everybody, and letting me introduce it a little bit. I just wanted to give you some background on how this came to be. So the name of the model is Emotional Attachment Behavioral Therapy. You can flip to the next slide. So the overview for EABT, Emotional Attachment Behavioral Therapy is a therapeutic model that's based on attachment theory, and it emphasizes how our attachment styles interact with our unhealthy behaviors and tendencies. Its central view is that when a person experiences attachment stressors, it can exacerbate thoughts, feelings, and behaviors that increase unhealthy outcomes for them. You can go ahead and flip it, Stephen. The primary objectives with EABT is number one, learning more about your attachment styles and your personal attachment characteristics, identifying your core attachment stressors and where they stem from in your life. And we're going to go through each of these objectives individually to talk more about them. Number three, learning your physical, emotional, and mental symptoms of trigger activation for early onset intervention. Number four, identifying and practicing coping skills to improve your ability for healthier responses. Number five, gaining awareness of your negative core beliefs connected to your attachment stressors and working to change them. Number six, learning how attachment patterns have been passed down, through your family and how to begin to break that cycle. Number seven, increasing the levels of secure attachment towards yourself and others to improve relationships in your life. And number eight, identifying all the stages of your attachment relapse cycle and how to intervene to enhance your healthy outcomes with your recovery. All right, so on the next slide. So forgive me for any of you that this is a review on, but I always like to go over just some of the basics of attachment theory for people, just so that they understand it. So British psychologist John Bowlby was the first attachment theorist, and he described attachment as a lasting psychological connectedness between human beings. Attachment is an emotional bond with another person, and Bowlby believed that the earliest bonds formed by children with their caregivers have a tremendous impact that continues throughout our lives. The central theme of attachment theory is that primary caregivers who are available and responsive to an infant's needs allow the child to develop a sense of security. The infant knows that the caregiver is dependable, which creates a secure base for the child to then explore the world. On the next slide, in the 1970s, Mary Ainsworth's groundbreaking Strange Situations study revealed the profound effects of attachment on behavior. So John Bowlby discovered the basic ideas around attachment theory and how it applies. Mary Ainsworth was the first person to really look at how some of this relates to behavioral stuff. And in the study, researchers observed children between the ages of 12 and 18 months as they responded to a situation in which they were briefly left alone and then reunited with their mothers. Based on the responses that the researchers observed, Ainsworth ended up describing three major styles of attachment: secure attachment, ambivalent insecure attachment, and avoidant insecure attachment. About 10 years later, researchers Main and Solomon in a follow-up study added a fourth attachment style called disorganized insecure attachment based on their own research. A number of studies since that time have supported these attachment styles and have indicated that these attachment styles have an impact on behaviors later in life. As we go through the EABT model, you'll see that we use these same four attachment styles in the EABT model. We've simplified the names a little bit just to make it easier for the clients we're working with, but the descriptions and the characteristics and behaviors of these styles are exactly what was described in this research. All right, next slide, please. So attachment styles are broadly categorized as being either secure or insecure. If your needs as a child were usually met right away by your caregiver, you probably developed a secure attachment style. As an adult, you most likely feel secure in your close relationships and trust that the other person will be there when you need them. If your caregiver failed to meet your needs as a child or was slow to do so, you may have an insecure attachment style. As an adult, you might find it hard to form intimate bonds with others. You may also have a hard time trusting those close to you. Okay, next slide, please. So how does all this relate to substance use disorder? Well, in the last decades, we have seen substantial growth in the amount of studies being done on attachment and substance use disorder. And the general link at this point between insecure styles of attachment and substance use disorder is well established. And there is moderate to strong evidence for the assumption that insecure attachment is a risk for substance use disorder. So how exactly does that work? Next slide, please. So when parents or other caretakers are responsive, children receive the foundation of personal security that's necessary to learn emotional self-regulation. Babies that do not receive predictable and appropriate attention from caregivers are unable to form secure attachments and thus resort to seeking alternative ways to calm their distress. In a study by Vega in 2023, they showed that insecure attachment creates in infants a series of distorted cognitive schemas and dysfunctional emotional interaction patterns that lead to dependency-prone personality profiles. So when these infants aren't developing secure attachments with their caregivers, it's not only that they don't have that safety within the relationship, it also really impacts some of their developmental ability as they grow up, right? And so one of the things we're really typically seeing from infants that grow up with insecure attachment styles is difficulty regulating emotions, difficulty managing stress, and difficulty developing support groups or healthy relationship factors in their life. So all those things get impacted by those early caregiver relationships. And just to use this for an example, if little 1-year-old Doug is in his crib crying and his mom comes in and picks him up right away, and pats me on the back and says, "It's okay, Doug, it's going to be all right." Not only do I feel safe and secure because my mom's right there when I need her to be, but also as I get older in life, what I'll find is when a stressful situation comes up 20 years later and I'm sitting in my car by myself trying to calm myself down, I'll say things like, "It's okay, Doug, it's going to be okay." So we learn to like mimic some of those secure attachments that we have when we're younger, and those lead to developing different strategies for ourselves on self-coping mechanisms. All right, can you flip to the next slide? So what happens to these infants when they become adolescents? For children with attachment disorders, the search for external form of emotional support and regulation continues into the teenage years when many people encounter drugs and alcohol for the first time. I don't know what middle school looked like for all of you, but for me, it was a hot mess. And you have all these young people who are going through all sorts of changes in their life and also developing more complex relationships at the same time. And so some of these young kids with attachment-based issues, those complicated relationship patterns that are developing in middle school can be pushing all of their buttons, all of their attachment buttons. And at the same time, drugs and alcohol are becoming more prevalent around that age. So it really creates a perfect storm for some of these individuals. Drugs and alcohol become reliable, easy, and powerfully effective forms of self-soothing for them. It is common for individuals with substance use disorders to describe their first drink or drug as a remarkable experience of feeling truly at peace for the first time. We're going to talk in a little bit about what exactly that means. In a study by Brandstetter in 2009, they demonstrated that securely attached adolescents at the age of 14 consumed fewer substances at the age of 16. In a study by Zai in 2014, they found that insecure attachment styles at the ages of 10 to 12 led to difficulty with regulating emotions at the age of 16 and substance abuse by the age of 22. And Jordan and Sack in 2009 calculated that secure attachment decreases the risk for substance abuse by odds ratios ranging up to 0.6. So the risk for substance abuse is almost 1/2 lower for people with secure attachments versus insecure attachment styles. The amount of research they've been doing around this stuff recently is really fascinating. And they've actually done research studies. I have to say, one of my areas of passion, being somebody who's been in treatment of adults with substance use disorder for so many years, I've got 2 teenage kids at this point, and I find myself really passionate around what can we do to start to get out more in front of some of these problems and start to work with younger and younger populations. So I'm really trying to be involved more with prevention groups here in my state and doing whatever I can. Obviously, I'm really excited how this model can help treat adults with substance use disorder, but it also gets me really excited thinking about doing some of this work to start to prevent some of these problems before they occur. In the research that they've done, they've started to assess adolescents coming into middle school based on attachment issues, and then follow up with them 3 to 5 years later. Their ability to predict who is the highest risk for substance use disorder in the future is getting really, really good. And not only that, not only can they predict with pretty good accuracy who's the most prone towards substance use profiles, they also can predict, based on what insecure attachment style you have, what drugs of choice you might be the most prone towards. So it's really fascinating how some of this attachment work is correlating with substance use disorder and how it could lead to preventative measures down the road. All right, next slide, please, Stephen. So other research that's been done around this, in a study by Fairbairn in 2018, results demonstrated that insecure attachment is a vulnerability factor for substance use, and further indicated that close relationship quality is a promising line of inquiry for future research on substance use disorders. So remember a little bit ago when I was talking about how these infants that don't have secure attachments have developmental stuff that comes up for them later. One of the areas I mentioned was developing close relationships. So they found that ways to start to improve people's ability to develop close relationship is a promising thing to focus on in treatment. In a study in 2020 by Cornella Font, they concluded that difficulties in regulating emotions linked to an insecure attachment style can lead individuals with substance use disorders to seek out new emotions or self-medicate. And Schindler in 2019 stated that based on attachment theory, substance abuse can be understood as self-medication, as an attempt to compensate for lacking attachment strategies. It's really interesting, once again, being somebody who has been in this field and been in recovery for a whole lot of years. Like I said before, I always love stuff that challenges my thinking and expands the way I look at things. Sometimes I don't initially love it, but in the long run, I end up really liking it. And one of the things when I was going through research around this that I found really interesting is, the disease concept has been such a big part of what I've learned over the years of my career, and I still absolutely believe in the disease concept. That being said, some of this research points to a different way that progression happens. It points to, I've got these insecure attachment buttons that get pushed in social interactions, which trigger unhealthy responses that lead to substance use disorder. Then my substance use disorder makes those relationships more complicated, which triggers more attachment issues, which triggers more responses, and the progression happens that way. So it was kind of interesting for me to look at an emotional progression through an attachment lens compared to some of the other ways that I've seen progression and the way that that is connected to the disease concept. So just an interesting little side note. Stephen, can you switch to the next slide? Thank you. And then in terms of implications for treatment when it comes to this research, a study by Gedhagen in 2018 found among patients with substance use disorder a strong relation between the patient's attachment style and their psychological distress. Knowledge of the patient's attachment style may help the therapist to tailor the treatment to the patient's needs. A change from insecure to secure attachment can be an important goal for substance use disorder treatment, as it may prevent the patient, from using defense strategies involving substance use for regulating emotions and interpersonal relationships. One of the things they've found through other research studies is that there's a strong correlation between successful treatment episodes that somebody has and long-term success that they have based on those treatment episodes, and how much their levels of secure attachment increase over the course of those treatment episodes. So even when they're using other evidence-based models, if their levels of secure attachment increase over that time, it greatly increases their success rate, which goes back to how I started this whole conversation off, which is me noticing early in my career that connections were a big part of treatment success. Schindler in 2019 concluded that results suggest that treatment approaches should consider insecure attachment in substance use disorder patients. Since there seem to be different types of insecure attachment, these should be assessed and become part of individual treatment planning in the same way as information about the amount of substances consumed, family history, co-occurring disorders, all of those different areas. All right, so Stephen, if you can flip to the next slide. So that takes us back to EABT and this model. And the first primary objective with emotional attachment behavioral therapy is understanding your attachment styles. Can you flip to the next slide? So the 4 attachment styles that we have in EABT, like I said, it's exactly the same as the research that Mary Ainsworth did in the Strange Situation study. We just simplified the names. So it's secure attachment, and then the 3 insecure attachment styles are anxious attachment, avoidant attachment, and fearful attachment. We're going to go through what each of these attachment styles are and some of the descriptions of them. I just want to say up front, if you're anything like me, anytime I'm listening to some of the stuff, I'm always thinking, how does it relate to me? Which one am I, And I would really encourage all of you, instead of thinking of this as which one of these am I, think of it as how much of each of these am I? Because here, after we're done with this presentation, you're all going to get to take the attachment style quiz, which may be something that's exciting or not or whatever, but you'll all get to take the attachment style quiz. And what it does is it'll rate you from highest to lowest on your attachment styles. So try to look at it more as a scale than, which one of these do I fall into. The other thing I would really encourage up front for all of you to keep in mind is these attachment styles are fluid, right? So when I first got clean and sober 24 years ago, I did not have a lot of secure attachment in my life. Thankfully, after 24 years, my attachments are more secure than they were. So my secure score has increased over time. And my insecure scores have decreased, which is what the goal is we want for these guys when they're in treatment or working with this model. I've also seen people that are extremely healthy and their attachment styles are very secure. And then they have something really traumatic happen in their life, like maybe they lose a spouse or something like that, and it can affect their level of secure attachment. So really keep in mind that not only do we have a little bit of all these styles, but they're always fluid and kind of changing. And so that's a good way to make sure we're looking at it. All right, so Stephen, if you can switch to the next slide. So the first attachment style is secure attachment. And people who have developed this type of attachment are typically self-contented, social, warm, and easy to connect with. They are aware of and able to express their feelings, and they tend to build deep, meaningful, and long-lasting relationships. Next slide, please. Some typical characteristics that you see with people with a secure attachment style: they're able to regulate their emotions and feelings in a relationship. They have strong goal-oriented behavior when on their own. They're great at bonding, opening up to, and trusting others. They're good at knowing what they're about in life and what purpose it is that they want to fulfill. They can communicate their needs effectively. They feel like they have an impact on the world around them. They are comfortable with closeness and mutual dependency. They actively seek emotional support from people in their lives and also give emotional support to people in their lives. They're comfortable being alone and use that time to explore. And I want to stop on that one for a second because you're going to hear us come back to that quite often, right? So, once again, as an infant, if when you cry out for help, your caregivers are consistent and they're right there responding to your needs, not only do you feel safer with your caregiver, you also feel safer taking risks and exploring your environment because you know if you get into trouble, they're going to be right there for you when you need them. So, so that definitely plays out into adulthood with, with adults who develop a secure attachment style. They become more comfortable with A, being alone, and B, using that time to explore new things, right? So maybe if I have a secure attachment style and my wife's going out with her friends, I'm excited to have a little bit of alone time and I want to cook a new dish I've been thinking about making or something like that, right? So you can see that stuff playing out for people in their adulthood. And then the last characteristic is having a strong capacity to reflect on how you were being within relationships. So being willing to look at yourself and analyze how you are within a relationship and what areas you can improve. All right, next slide, please, Stephen. So the next attachment style is called anxious attachment. And people with an anxious attachment style might think highly of others, but they often suffer from low self-esteem. These individuals are sensitive and attuned to their partner's needs, but are often insecure and anxious about their own worth in a relationship. If the loved one rejects them or fails to respond to their needs, they might blame themselves or label themselves as not being worthy of love. Adults with anxious attachment need constant reassurance that they are loved and cared about, that they are worthy and good enough. And next slide, please. Some of the characteristics of anxious attachment are lacking a strong sense of self and having low self-esteem, having a tendency to put others and their needs first, having a strong desire for relationships and intimacy and a hard time being alone, seeking approval and reassurance from others constantly. I don't mind sharing this one with you guys. My wife always teases me that anytime I do any sort of chore around the house, I can't just do the chore. I need to make sure. Oh no, please don't switch that. Thanks, Stephen. She always teases me that I can't just do the chore. I have to make sure she notices that I did the chore, right? And she'll always tease me that like, oh, do you need a cookie for doing the dishes? And but I've got that characteristic inside of me through some of my attachment stuff that it's hard for me to do any task and not get some sort of reassurance, whether it's at home or at my job from my boss, things like that. So I definitely have seen this one play out for me. Other characteristics with anxious attachment is clingy and needy behaviors in relationships, having a strong fear of rejection, criticism, and abandonment, becoming extremely upset when receiving disapproval, having jealousy and frustration when the partner is unavailable or inattentive, overanalyzing and worrying excessively about relationships. That's something else that I fall prey to a lot is if there's like a difficult conversation I'm getting ready to have in the next day or so, I'll analyze it to death. I'll play it through in my head a million different ways, and it just increases my anxiety by the time I actually have the conversation. Also, if I ever have difficult situations, I'll replay them over and over in my head and think how I wish I would have responded differently or stuff. So I definitely have that tendency to overanalyze at times. And then the last characteristic with anxious attachment is easily ignoring or misreading signs of relational issues. And what that means, in a sense, is if your friend is too busy and can't get together with you for a certain activity, instead of you thinking, oh, okay, they're busy, you might think, uh-oh, are they mad at me? Did I do something? What did I do that made them mad, right? So you tend to misread signs that are going on and take things personally that maybe you shouldn't. All right, let's flip to the next one, Stephen. Oh, I know, really quick too. You don't have to go back, Stephen, but one thing I want to mention really quick is through my research with this developing this therapy model, one of the things I found through my experiences is that a lot of those characteristics with anxious attachment seem to correlate really well with people with codependent tendencies, right? So it seemed like there was a strong correlation between codependency and anxious attachment style, which is interesting. Okay, so the next attachment style is called avoidant attachment. And for avoidant adults, social interactions and bonds remain on the surface. These individuals will let you be around them, but they will not let you in. Adults with this attachment style believe that they do not need emotional intimacy in their lives. An adult with an avoidant attachment style might look confident, strong, and together, but this does not mean that this person is not suffering or making those around them suffer. To the avoidant adult, emotional closeness and intimacy are often off the table. Next slide, please. Typical characteristics that you see with people with an avoidant attachment style is avoiding intimacy with others and a preference for distance, tendency to pull away as soon as someone tries to get close, high self-esteem and not relying on others for reassurance or emotional support, uncomfortable with opening up to others and expressing private thoughts, dismissing behaviors and aloofness. I don't know if any of you guys have worked with people in your life where a new coworker comes onto the team and they say, hey, I don't think Joe likes me very much. And people will say, oh, that's just Joe. It takes him a while to warm up to you, right? I think, a lot of that can connect to some of this type of an attachment style for people. Minimizing emotional expressions is a characteristic with avoidant attachment style. Seeing yourself as self-sufficient and independent. Think about, from my experience, I don't know about you guys, but from my experience, so many people with substance use disorder have a really hard time asking for help. They really struggle asking for help. So look at how that could connect with some of this attachment stuff. Appearing as strong, confident, and in control, believing that you don't need emotional intimacy in your life, and difficulty trusting and relying on others. One of the things I go around and do 2-day certification trainings for different organizations that want to implement this model. And so many times when I'm doing the training with groups, people will point out that they're either anxious or avoidant is their primary attachment style, and their spouse is the other one, right? And so it seems like you see a lot of avoidant and anxious matching up together at times. And I know that definitely can relate to my relationship as well. And something else, when I was early in my career, the term counter dependent, I don't hear used as much as it used to be, but there used to be a lot of talk about there's codependency and then counter dependency, and codependence and counter dependence match up really well. And, kind of like jokes that if a codependent and a counter dependent are in a crowded room, it's like a magnet that draws the two of them together in a crowded room. I think you can see a lot of similarities in characteristics with avoidant attachment and counter dependency, the same way that you can see similarities between anxious attachment characteristics and codependency. So it's interesting how all that stuff kind of correlates. All right, the next slide, please, Stephen. And so the last of the 4 attachment styles is the fearful attachment style. Keep in mind when I'm going through this one that this is the one that Main and Solomon discovered 10 years after the Strange Situation study. And it was initially titled the disorganized insecure attachment style. And you can kind of hear why they titled it that way when I go through the description. So adults with fearful attachment style lack a coherent approach towards relationships. On the one hand, they want to belong, they want to love and be loved, while on the other hand, they are afraid to let anyone in. They have a strong fear of getting hurt by the people who are closest to them. They do not reject emotional intimacy, they're simply afraid of it. Adults with a fearful attachment style continue to view the attachment figure who was once their caregiver and it's now their partner as unpredictable. They have trouble believing that their partner will love and support them as they are. These adults expect and are waiting for the rejection, disappointment, and hurt to come. Next slide, please. And the characteristics with fearful attachment style are unable to regulate emotions, strong fear of being hurt, rejected, or abandoned by loved ones, being chronically vigilant and anxious, having low self-agency or a sense of not having an impact on the world around you, feeling ineffective and helpless in life, having very poor goal-oriented behavior, difficulties with bonding, opening up to, and trusting others, showing contradictory behaviors in intimate relationships. I hate you, don't leave me, things like that. Alternating between clinginess and aloofness. And one of the things I found when, looking over some of these characteristics, once again, this is just my experience, but I saw some correlation between the characteristics of fearful attachment and some of the traits that you'll see at times with borderline personality, which, once again, I think it's understandable why they initially called that, why they initially called it disorganized and insecure because of some of those responses. So I definitely see some of the traits between that and borderline personality disorder. All right. Next slide, please. So when a client comes into an EABT group, and something I'll mention really quick, I designed this model for our groups in a residential setting. 3 years later, as I sit here now, it's being used in group settings and treatment centers, both in residential and outpatient. I've got mental health therapists that are using this model for individual therapy with clients. I found out very quickly as I was going around presenting this model, people would come up to me and say, this would work really well with this behavioral health area or this area. And so, attachment theory in a nutshell is such a foundational model that it works with a number of different areas besides substance use disorder. But the focus in this presentation and how this model was initially designed was for substance use. When a client starts working with EABT, the first thing we do is we educate them on the 4 attachment styles. We want to make sure they understand what the 4 attachment styles are. And then we have them take the attachment style quiz. And the attachment style quiz, this is just an example of the attachment style quiz, but the attachment style quiz is a 40-question quiz with 10 questions connected to each of the 4 attachment styles. And after you take the quiz, it gives you a score for each of your attachment styles, so you're able to rate them from strongest to weakest. The other thing that it does is it gives you your top insecure attachment characteristics, right? So number 3 on the screen right now, when my partner arrives home or approaches me, I feel stressed when they want to connect. That characteristic is connected to avoidant attachment style. So if I scored a 4 on that one, that I feel like that's something I'm always prone towards doing, not only would that 4 go into my overall score for avoidant attachment at the end, it also identifies a specific individual characteristic that I have difficulty with. And the reality is those characteristics can lead me towards stress reactions that lead me back towards substance use. So it's important that not only we understand our attachment styles, it's also important that we understand our individual attachment characteristics that can lead us towards unhealthy outcomes again. Okay, next slide, please, Stephen. So the next primary objective for people after they've learned about the attachment styles and taken the quiz and learned their attachment styles and characteristics, the next thing we want them to do is gain awareness of their core attachment stressors. So what exactly are core attachment stressors? Next slide, please. So core attachment stressors in a nutshell are childhood environmental factors that impacted us and unmet needs that those created within us. So in terms of childhood environmental factors, what research has shown is that quite often there's certain childhood environmental factors that can be prevalent towards developing different attachment styles. Next slide, please, Stephen. So for instance, with secure attachment, you can quite often hear about childhood environments where the child felt very safe and protected. The child felt seen and positively responded to. They felt comforted when distressed or soothed when in pain. They felt reassured that everything would be okay. The child felt valued or unconditional love. They felt supported to explore. There is that thing again that we talked about before, right? Being comfortable going out and exploring your environment. They felt safe taking risks, and they also felt safe expressing their feelings. Next slide, please. For anxious attachment style, you'll quite often hear about childhood environmental factors like receiving inconsistent parenting patterns, not being responded to consistently when needing something, feeling responsible for your caregiver's emotions, feeling like your physical space was intruded on, the child feeling overprotected or feeling like the caregiver was, was overly focused on them, the child feeling like the caregiver was overly intrusive, the child feeling responsible to make the caregiver feel loved, or feeling responsible to make the caregiver look like the perfect parent. Also, a child who's separated from their caregiver at a very early age. You know, one of the partnerships I'm developing from a previous presentation that I did, I had a group that works closely with adoptees approach me and talk about how this model can work really well with adoptees. And so we're developing a curriculum that's specific for that population. But thinking about being separated at an early age and the impact that has, you know, it definitely can affect a lot of these individuals. Also, you know, focusing on some of these environmental factors with anxious attachment that I just went over. I mentioned before that the characteristics that people with anxious attachment can show correlated with codependency. Personally, from my experience with adult children of alcoholics and also growing up in that type of an environment, I think there's a lot of correlation between the environmental factors for anxious attachment and some of those adult children of alcoholic environments that grow up. And once again, using myself as an example, you know, for inconsistent parenting patterns, you know, I had one parent that was in the middle of their alcoholism and another one that was trying to compensate. So it was extremely inconsistent. Feeling responsible for your caregiver's emotions. You know, my mom was not going to get her emotional needs met from my father, who was in the middle of his alcoholism at that point. Where do you think my mom got those emotional needs met, right? And so a lot of that falls down onto the kids. And feeling you know, feeling responsible to make your caregivers feel loved or look like the perfect parent. I grew up in the 80s, and when my dad ended up going to treatment finally, we couldn't tell the neighbors he went to treatment. He went on a 30-day business trip, right? Like it was back in those days. And part of our job as kids was that, and this was never spoken about, it was just unconscious, but we had to always keep up the family image as looking like the perfect family to all of our neighbors around, right? And so so the focus would never be on my dad's alcoholism. And so I definitely can see how a lot of these correlate not only with my own story, but a lot of the people I've worked with throughout my career. All right, next slide, please, Stephen. All right, with avoidant attachment style, you'll typically hear about childhood environmental factors like the caregiver was overly strict towards the child, the caregiver was emotionally distant, the caregiver did not tolerate expressing feelings, How many of you can relate to hearing, I'll give you something to cry about when you were a kid growing up? That was something that, I think some of this too, it's not about good or bad parenting. It's about generational stuff, cultural stuff. So there's so many factors that play into this, right? The caregiver expecting the child to be overly independent or overly tough. The caregiver not being emotionally available for the child, the caregiver not being attuned to the child's needs, the caregiver being overly reserved, or the caregiver would back off when reached out to for support, reassurance, or affection. And the stronger the emotions, the more unavailable the caregiver would be. All right, next one, please. And then for fearful attachment style, you tend to hear about childhood environmental factors like the child suffering from abuse, suffering from childhood trauma. The caregiver was a source of fear. The caregiver showed highly contrasting behaviors. Think how much of the time, if you're growing up in an environment where substance use disorder is going on, where at one point your caregiver might be very loving and kind, and then the next minute they're lashing out at you, right? So these really unpredictable, unsafe environments that kids are growing up in. Your caregiver was extremely inconsistent or was very unpredictable. The caregiver caused the child to fear for their safety. The child could not trust the caregiver. They couldn't rely on the caregiver to meet their physical or emotional needs, and they felt like they never knew what would happen next. All right, next slide, please, Stephen. So after the participants in EABT take the attachment style quiz, the next thing we have them do is take an attachment childhood quiz. And what this is it's a 40-question quiz, and it's got 10 questions connected to environmental factors for each of the 4 attachment styles, right? And so, for instance, with number 3, my caregiver was overly strict when I was a child. If that's one that I rate really high, I'm identifying an environmental factor that had a big impact on me. Now, I will say the goal with this quiz is not what your overall score is. It's not necessarily what the overall score for each of the attachment styles is. That really has nothing to do with it. It's more like an adverse childhood experiences assessment that I'm sure we all use regularly. Where really what you're doing is identifying these specific environmental factors that had a big impact on you when you were growing up. All right, next slide, please. So after the participants take the childhood attachment quiz, this is just an example of the next exercise, but this one's called Childhood Experiences and Unmet Needs. Sorry that the lines under unmet needs aren't accurate. I don't know exactly what happened on that, but on this exercise, what they end up doing is they identify their top 5 childhood experiences that they identified from the previous quiz that had an impact on them. And then for each one of those childhood experiences, they look over the list of unmet needs. And once again, this is an example of this exercise. On the actual exercise, the list of unmet needs is a lot longer than this, but they get to pick 3 specific unmet needs that correlate to that childhood experience, right? So let's say my caregiver was overly strict, like I mentioned before from the childhood quiz. Let's say that's one that somebody identified as one of their top 5. They could look over this list of unmet needs and decide for themselves which ones of those unmet needs do they feel like are the most correlated to growing up with an overly strict caregiver. One of the things I didn't mention, when we have people take the childhood quiz, one of the things that we say to them is that when you're answering each of these questions, if one parent was really good in this area and another one of your caregivers was really not good in this area, when you're rating this, focus on the one who had difficulties in this area. So let's say, my caregiver was overly strict. Maybe my mom wasn't strict at all, but my dad was overly strict. When I'm rating that question on my childhood quiz, I want to just be focused on my dad. And the reason for that is what we don't want is all of these to get balanced out in the middle because you have 2 opposite parents. Because the reality is, if one of my caregivers is really overly strict, that's going to create an attachment wound in me. And so I really want to be able to identify that specific attachment wound for further work that I'm doing. So back to this exercise, when they're doing this one, they end up identifying their top 5 childhood issues. And for each one of those, they identify unmet needs that correlate to that. So for instance, like I mentioned, if having an overly strict caregiver was my childhood issue, maybe for me, my unmet needs around that were safety or support or appreciation, or maybe I felt like I didn't have any freedom or any connection or any nurturing. I get to pick the unmet needs that seem most important to me that correlate to that issue. And when clients present this exercise to a counselor and they present their top 5 childhood experiences and 3 unmet needs for each of these, after they're done going through all of those, the counselor will quite often say, now I want you to look at this list of unmet needs that you just put together on this exercise. And then I want you to think back on that first time you used drugs or alcohol and you felt like you fit in your own skin for the first time. How many of those needs were being met in that moment for you? And what you see is a light bulb go on for these guys where for the first time they're really able to correlate how this stuff connects to some of those childhood attachment issues and their substance use disorder. All right, next slide, please. So now with each of these clients, they've identified their attachment styles, they've identified their individual attachment characteristics, they've identified their core attachment stressors, which include their childhood environmental factors and their top unmet needs that have had an impact on them. The next thing we want to do is look at identifying their symptoms of trigger activation. So next slide, please, Stephen. So on this exercise, what we do, and once again, this is just an example of the exercise. It's not what the actual one is, but on this exercise, what we end up having them do, they have long lists of physical symptoms, emotional symptoms, and mental symptoms of trigger activation. And they end up identifying when these attachment buttons get pushed for them, what are maybe the top 5 physical symptoms that manifest for them? What are the top 5 emotional symptoms? What are the top 5 mental symptoms? So they're really starting to look at when these buttons get pushed for me, how does this respond in symptoms of activation for me so that they can catch these cycles when they're coming up. And the other part with this exercise is we almost have them do like a mini relapse cycle where they take their top unmet needs that they've identified that correlate to their substance use disorder. And let's say one of my top unmet needs is safety. I would write that down and then look at, okay, if that safety button gets pushed for me, what's likely to be a physical symptom that I might experience, an emotional symptom, a mental symptom? So maybe I say when my safety button gets pushed that I have difficulty sleeping. Maybe for an emotional symptom, I feel extra anxious. Maybe for a mental symptom, I start to have a lot of negative thoughts about myself. They get to identify those specific symptoms of trigger activation that are prevalent for them. And then they also get to look at what unhealthy behavioral responses might come from this, right? Or what's been referred to for a lot of years in the field as relapse behaviors, right? So it could be fight, flight, or freeze type of responses that come up. It could be isolation that comes up. They get to look at when these buttons get pushed and these symptoms of activation come up, how can I respond in unhealthy ways that leads me back towards substance use again? And once again, I want to go back and remind you guys at the start when I was talking about designing this model, I talked about how I wanted it to be self-directed for the client and empowering for them. So notice that every step of the way, we're letting them identify their own things. They have long lists of stuff to work from, but they're getting to pick what they work on and what areas they think are important to them. And that really creates that self-direction and that empowerment that we want. Another thing that I'll just mention quickly while I'm thinking about it, one of my concerns that I had when I rolled this model out is that it could lead to blaming our caregivers instead of looking at our own stuff. And it's actually been pretty surprising in that regard. really the main thing that I have seen by people doing this work is that learning about their own attachment styles helps them to see that their caregivers had their own attachment styles, and it kind of allows them to look at this as a cycle, which actually has increased the level of empathy and forgiveness towards caregivers. And we really do a good job with this model on constantly focusing on this is about you understanding why you respond the way you do so it can empower you to change those responses. So it's really led to extra empathy towards caregivers and a feeling of empowerment for the individual. All right, next slide, please, Stephen. All right. So the next primary objective with the EABT is cultivating coping skills. Now they've really done a good job of digging in and learning these negative cycles that can develop from their insecure attachment styles. Now we want them to be practicing some coping skills to utilize this. And you guys will see as we go through this model, there's a lot of times I'm utilizing CBT, DBT, relapse prevention, different techniques. So this definitely is an amalgamation of other models, and I try to utilize those where I can. So next slide, please, Stephen. So on this exercise, what we end up having them do is they identify their top 5 unmet needs that they've identified correlate to their substance use disorder. And for each of those unmet needs, they identify alternative coping skills that can help them when that button gets pushed for them, right? And once again, the actual list of coping skills is much longer on the actual exercise than it is here. Interesting side note, over the last few years, as clients have worked with this model, at times I've been sent emails asking to add new coping skills to the list of coping skills, which has been really cool that they've taken a degree of ownership and empowerment, wanting to, add to the model and improve it, which I'm always very receptive to. So, I mean, I have to say there was a couple where I was like, I don't know that I'm going to put that on the list, but for the most part, their ideas for alternative coping skills were very good and a welcome addition. So on this assignment, they identify their top 5 unmet needs, 3 alternative coping skills for each of those unmet needs. One of the things I really love about this exercise is, for years teaching coping skills to clients, a lot of times when we're teaching coping skills, it's just around stress in general. But with this model, it individualizes the coping skills to the unmet need button that might be getting pushed, right? And so if one of my top unmet needs is safety, what the coping skills that are going to help me with feeling a lack of safety are going to be different than the coping skills that might help me with my unmet need of connection or of freedom, right? And so it really individualizes coping skills towards the specific stressor that's going on for people. And something you'll quite often see as we're getting to this, these points in the model, we're constantly looking at taking what the client is learning and applying it to their everyday life, right? So if I'm a client and I share with the counselor that I had an argument with my wife on the phone, the counselor might ask me, what feelings came up for you during that disagreement? Were you able to identify any unmet need buttons that got pushed for you? Maybe I say, yeah, it was that security button again got pushed for me. Did any of your symptoms of trigger activation come up? Yeah, my anxiety went through the roof. I started to get really short of breath. Did you feel yourself wanting to engage in any unhealthy behavioral reactions? Did you utilize any of your healthy coping skills? Yeah, I reached out to one of my peers. Good job, good job. So we're always looking as people go through this model, relating it to what's going on in their life so that they can connect those dots. That's a really critical part as they're going through this. All right, next slide, please, Stephen. All right, so the next objective with EABT is improving self-esteem, and you can flip to the next slide. So this exercise is a negative core belief exercise. Once again, it's a typical CBT type of exercise. And what they do is they complete this diagram 5 different times. And on this diagram, they take the previous exercise where they identified their top 5 childhood experiences and 3 unmet needs. they write those into the 5 blank diagrams. And then for each of those diagrams, they look at negative core self-beliefs that have developed from that, negative core beliefs of others that have developed from that, and negative core world beliefs that have developed from that. And this really is an interesting assignment. First off, on the exercise, they have a long list of self-beliefs, beliefs of others, and world beliefs that they can pick from. Clients are always encouraged, if something isn't on the list that you want to use, feel free to use it. But let's go back to the example I used earlier. Let's say I had an overly strict caregiver, and my unmet needs were safety, support, and freedom. What negative core self-beliefs might have stemmed for me from having an overly strict caregiver? Maybe I feel like I'm stupid. Maybe I feel like I'm a failure. What about beliefs of others? Maybe I feel like no one understands me, or I don't need people anyway. And what about world beliefs? Maybe I feel like there's no point in trying anyway because I never do anything right, you know? So we really start to take a look at not only how these attachment wounds affected our unmet needs, but also how they affect our view of ourselves, our view of other people, and our view of the world. And something I want to mention really quick, once again, being in the field. Oh, and it's important to understand right after they do this exercise, they do an adjusting negative core belief exercise where they take their top negative core beliefs and start to work on how to adjust those and improve those. But going back, one thing I was going to mention, being in the field for a long time, this is probably different than a lot of you, but it might be the same. One of the biggest assignments I've seen patients do in substance use disorder treatment settings is called a timeline assignment. I don't know how many of you are familiar with timeline assignments, but on a timeline assignment, the client will stand up in front of their group and pretty much tell their life story and the progression of their substance use disorder, right? And there's positive therapeutic benefits that come from this exercise. Everyone gets to know the client better. The client gets to really look at the progression of their substance use and consequences and things like that. So there are positive therapeutic things that come from that. One of the downsides, though, from being a clinician working with those types of exercises is quite often when clients are sharing their life story and the majority of them have trauma in their history, they end up sharing about trauma. And you have to be really careful about, interventions that are necessary if the client starts to go there and talk about trauma in a group format, because not only obviously can it trigger them, it can also trigger their group mates. And then the other areas, when they're talking about their use and the progression of their substance use disorder, talking about use can trigger people in the group. So even though assignments like timeline assignments have therapeutic value, they can also be slippery slopes in some ways in terms of creating unhealthy dynamics within the group. This is the deepest level assignment that they do in EABT. And one of the things that is great about this is, let's say that one of the childhood issues that I identified that has come up in my life is childhood trauma. I would put that under my childhood experience, and I immediately go to unmet needs that come from that childhood trauma. And what I've talked to a number of people who've gone through EABT groups who've got a history of trauma. And one of the things they always say is, this is some of the best treatment around trauma I've ever had. And I never had to tell the story once about what happened to me. It just focused on how it impacted me and what I can do to change it, And so that's really promising. And you'll see when I get to some of the data around this that people with a history of trauma have some of the highest success rates with this model, which is really encouraging as well. All right, next slide, please. So the next primary objective that we work on with EABT is intergenerational attachment patterns. Next slide, Stephen. And with this one, I don't know how many of you are familiar with genograms. I'm a big fan of genograms. I've used them throughout my career, but with this exercise, this is just an example of a genogram. Each client draws their own genogram with them in the middle, however many caregivers that were impactful to them above them, their partners that have had an impact on them to the side of them. And it's got two because maybe, I'm in a current relationship, but there's also an ex partner that was in my life for a long time that would be good to look at, that individual. And then any children in our lives are down below us on this genogram. Next slide, please. And for each one of these circles, they end up identifying for each circle what they think the individual's most common attachment style was, some of their top attachment characteristics, and some of those individuals' top negative core beliefs. And they end up looking at how this is all interconnected for them. So how did their caregivers' attachment styles and characteristics play into their attachment styles and characteristics? How did their caregivers' attachment styles and characteristics play into their choice in partners and their attachment styles and characteristics? When applicable, how are they passing down their attachment styles and characteristics to children in their life? So they really get to start looking at this from a cycle type of standpoint, and really see how this all plays in together. And once again, this really helps with people having more compassion for their caregivers and also being more motivated towards breaking the cycle for the next generation coming up. Intergenerational trauma is something that's talked about regularly in our field nowadays. And there's a study that I heard that I thought was really impactful. Some of you may have already heard this, but they did a typical behavioral experiment with some mice. And it was a typical Skinner type of behavioral experiment where they had these mice smell a strong apple smell, and then they would receive an electric shock afterwards. Not surprisingly, within a very short period of time, these mice would smell the apple smell and have a negative reaction because they knew the shock was coming. Once again, that's a typical behavioral experiment, not surprising at all. What was surprising is the mice's children that had never received a shock responded the same way to the strong apple smell. The mice's grandchildren responded the same way to the apple smell. They're now on like the 8th generation of these mice, and they're still responding negatively to that apple smell. So if you think about that in terms of intergenerational trauma and some of the cultural parts of that get passed down, think about if mice are responding that way, what are we going to learn over the next 30 to 50 years about how trauma is passed down from one generation to another? I find that stuff really fascinating. All right, next slide, please, Stephen. So a lot of the work up to this point has been understanding insecure attachment styles, how they negatively impact us, how to respond to those in different ways. But the next thing we really want to be focusing on is building secure attachment styles. That's a really important component with this. We don't just want to see their insecure attachment styles decreasing. We want to see those secure attachment styles increasing. Next slide, please. So they do a lot of different exercises with this model on ways to improve levels of secure attachment. They work on characteristics of secure attachment and how to practice those on more of a regular basis. They work on how to develop environments in their life that are more conducive towards secure attachment. They look at each relationship in their life and how to improve the levels of secure attachment within that relationship. So they do a ton of work on how to increase secure attachment. And also the counselors, every time I do trainings around providing EABT for organizations, the counselors are constantly talked with and trained on how to provide environments that are conducive for developing secure attachment, whether it's in the individual one-on-one relationship with a client or when applicable group norms in terms of a group environment that you want. And the environments that the counselors are trained on is exactly the same as the environmental factors that I went over from childhood environments that create secure attachment for people. So the clients are looking at how to create, or I'm sorry, the counselors are looking at how to create safety for the clients, how to make it clear that they see and hear the clients, how to respond positively to the client, comfort the client when distressed, soothe them when in pain, display that you value them, an unconditional positive regard, support the client in exploring and learning more about themselves, support the client in feeling safe taking risks, and support the client in feeling safe expressing their feelings. And that doesn't mean that you can't ever challenge areas that need to be challenged, but it's just really important with this model that we're always putting safety first, and that we're creating that type of a container where people feel safe to do the self-directed and empowering work that we want them to do. Something that's interesting too, I worked with a group of adolescents at a high school here in Oregon around this model. And the most common thing that those adolescents reported in terms of environmental factors that impacted them in their childhood was not feeling safe expressing their feelings. And these were all adolescents that had difficulties with substance use disorder. So it's interesting learning more about which environmental factors are having some of the biggest impact on people. But definitely not feeling safe expressing your feelings is something that was very prominent within this group. All right, next slide, please. And then the last of the primary objectives is relapse prevention. Next slide, please, Stephen. And so with relapse prevention, this is one of the last assignments they do. And this really is a culmination of all the work they've done up to this point. So first off, they identify high-risk situations for themselves. And keep in mind, high-risk situations aren't viewed in this regard as I went to the bar or I went to a party. My experience with relapse is quite often the high-risk situations that start a relapse process are difficult interactions that we have with people close to us in our life. By the time we end up at a bar or a party, we've kind of, gone a ways down that road at that point. So we really have them identify high-risk situations that could come up in interactions with people that they're close to. And then once again, they go through all the areas they've learned up to this point. So what feelings might come up, what unmet needs might come up, what attachment signs of trigger activation might come up, what alternative coping skills might come up. They go through the whole thing for each of these high-risk situations to look at if it goes the wrong direction, what's that going to lead to? And if it goes the other direction, what it's going to lead to. And once again, this is typical like Terence Gorski type of relapse prevention work, just with an attachment lens added to it. All right, Stephen, next slide. So as I mentioned before, not only were clients really interested in utilizing the EABT model when we first opened it up, but over a period of time when we got to start to look at the results, the success rates were really fascinating with these guys. First off, one thing that we found, we're partnered with Oregon Research Institute here around doing a longitudinal study over the next 5 years to lead EABT towards being an evidence-based practice. This is around the pilot data that Oregon Research Institute conducted. It was over a 12-month period with over 700 patients. So it was a pretty large pilot study, but still it's initial pilot data. And all of these patients got to choose between going into the EABT groups or the other control groups, which were evidence-based practice, DBT, CBT, things like that. And one of the things that we found was that the completion rates, the rate of completing their treatment experiences were 11% higher with the EABT groups than the other evidence-based practice groups. The rates of following through to the next level of care were 13% higher with EABT. The rates of atypical discharge, ACA, AMA, blowing out of treatment early, were almost half as much with EABT as they were with the other evidence-based practice groups. And then the length of stay, the amount of EABT patients that were asking to extend because they wanted to keep doing this work was a lot longer. It was 15% higher than the other evidence-based practice groups. One of the things that's really been identified through the research is that the levels of engagement into these groups is a lot better with EABT, and I think a lot of that's the safe environment that they're coming into, and also a lot of the retention is greater in these groups, and I think a lot of that is because of the connections that they're building with their peers. I found it interesting when I saw that they were doing a better job of following through to the next level of care, so I followed up with quite a few patients and asked them around that. And it was interesting. What they said is the relationships they developed in their previous group, they felt like they owed it to those people to follow through on their word and go to the next level of care, which was really exciting. The other part was they said because of the relationships they developed in that previous group, they were more hopeful that they could develop similar relationships in their next group. And that's exactly what we want, right? It's not all about building secure attachments within this group. It's about how building those secure attachments can lead to them building secure attachments throughout the other parts of their life. So that was really exciting to hear. Next slide, please, Stephen. And then the other areas that were really interesting, people that had multiple high-risk factors were 7% higher completion rates with their treatment episode than the evidence-based practice groups. People with a history of suicidality had a 10% higher completion of their treatment episode rate than the other evidence-based practice groups. And this is one of the areas that I was talking about earlier that I'm so excited about. People with a history of trauma had an 18% higher success rate with this with EABT than the other evidence-based practice groups. So that part I get really excited about. And patients that were 25 and under had a 21% higher success rate with EABT for their treatment experience than the other evidence-based practice groups. And I think a lot of that goes back to what I was talking about with the generations coming up, don't handle being disempowered as well. They really want something that's self-directed and empowering. And I also think, just like everybody else, a lot of those generations are really hungry for connections and building connections in their life. So those parts were really interesting. Another thing that I think I mentioned earlier, but I'll mention again, that the research through Oregon Research Institute showed was that people with these co-occurring areas, suicidality, trauma, things along those lines, were much more apt to pick EABT to work in than the other evidence-based practice groups. So that's something that's really interesting too, is that they felt safer going this direction with their treatment than the others. So I found that interesting. Okay, next slide. And then this is pretty interesting. I mentioned before working with adolescents at a high school last year. So in Portland, Oregon, which is just north from where I'm at, there's a place called the Harmony Academy. It's a recovery high school. I don't know how many of you are familiar with recovery high schools, but they're really cool and they're starting to spread across the nation, which is exciting. But we worked with these recovery high school students for a period of time. And there was 12 of them within the EABT group that we did up there. I worked closely with the principal of that high school. And when we gave all of these individuals the test, the attachment style quiz at the start of using the model, and then took the averages from all 12 of those people's tests, you can see on week 1 right here that their insecure attachment styles were the highest scores, and secure attachment was down closer to an average of about 24. And over the next 6 weeks of working with this model, 6 weeks later, we tested all of them again and once again took all of their averages. And look at how all those insecure attachment styles are coming down and their insecure attachment style is going up. Once again, this is a small sample size. This is just pilot data. Excuse me, but it's exciting. It's exciting to see that this is working the direction that we intended it. So that's really neat. All right, next slide, please. And then some quotes that I've gotten from people who have completed EABT. One is, I finally have a definition explaining why and how I feel and react to things in my world that hurt me. Next slide. Understanding my root issues and attachment patterns is more than I ever could have imagined getting from treatment. Next slide. The EABT counseling style of working with my beliefs, my perceptions, and my truth of my world as I knew it allowed me to feel heard, seen, and understood for the first time in my life. This one really hits a soft spot for me because really what I hear that person saying is they developed the first secure attachment in their life, which on one hand is heartbreaking, but on the other hand, it's really rewarding because that's what this model was designed to do. So it's really exciting to see that. Next slide, please. And this person said, it's like I found the lock and key. Next slide. So this is the branding symbol that we came up with for EABT, which I like a lot. All right, next slide. Okay, and then outlook for EABT and what direction this is moving in. As I mentioned before, we're doing research with Oregon Research Institute, doing a 5-year longitudinal study to move EABT towards becoming an evidence-based practice. There's also a research project that we're partnered with the University of Oregon and Oregon Research Institute on, where we're developing an EABT curriculum for parents that are involved in child welfare services to work on how EABT can help with parenting techniques. It's pretty fascinating. I could give a whole nother talk on this thing, but there's 4 parenting styles that correlate pretty interestingly with the 4 attachment styles. So in that parenting curriculum, we're having people look at their attachment styles and also their parenting styles and how some of these cycles have played into things and how to start to develop more secure attachment and healthier parenting styles with their kids. And like I mentioned before, I get really excited thinking about how we can use some of this type of work to start to get out in front of some of these behavioral health problems and possibly stop them before they occur. In terms of curriculum with EABT, like I mentioned before, I developed a substance use disorder workbook that's being used, widely around the nation at this point at different places. And then I developed an adolescent substance use disorder workbook that's being used as well around the nation. And I'm in partnerships looking at creating curriculum using EABT, like I mentioned before, for parenting. There's one I'm doing with a group of people around first responders. I'm developing one for LGBTQ population for substance use disorder treatment. As I mentioned before, working with a group for adoptees. And there's also an advanced curriculum that we're working on for therapists. Even though therapists are already using this model in their therapy, we're working on an advanced one for mental health therapists to be using. And I'm with a group of people working on developing a peer support model. And that's one thing I haven't mentioned yet that I will really quick. One of the things that's really interesting with this model is not only do you do a deeper level of work through the model, but it's so self-directed. And the clinician's job is so much around just keeping the environment safe and having a safe container to do the work with you, that one of the things we really found at organizations that I'm partnered with is that you don't have to have a ton of experience or high credentials to be practicing this model. So even though mental health therapists are using it, there's a lot of substance use disorder counselors that are relatively new in the field that are using this model and being very successful with it. And that's why we're also looking at developing it for peer support. So I think this model can have a lot of adaptability, and considering the fact that a lot of us throughout the nation are short-staffed when it comes to behavioral stuff, and that the levels of experience on our teams have dropped a lot throughout the pandemic. I think this model works really well to do high quality work with people that don't necessarily have years and years of experience. Not that people that have years of experience can't work well with it, but newer people in the field, I think, can work well with it as well. And then, as I mentioned before, partnerships. I've been working on creating partnerships around the nation, and I was excited to get to partner with growth partners today to do this presentation for you guys. And I'm going around different states. I'm partnering in Tennessee and Texas and Colorado and different states around the nation to bring EABT to different organizations. I think that is it on the presentation. If you can flip to the next slide, Stephen. So the next thing we're going to do as part of this presentation, I'm very much into experiential trainings. I always feel bad when people just have to listen to me for the whole time. And I always like to get people involved in trainings. I find that stuff works well. So I'm hopeful that you guys are willing to participate in this. This is usually a pretty fun activity. This is the attachment style quiz that our participants take. And if you scan it with your phone, it'll pop up a link to my website where you can take the attachment style quiz. It's a 40-question quiz, and at the bottom, you'll hit show the results. And what will pop up is your scores for each of your attachment styles and your top 5 insecure attachment characteristics that the test identifies for you. So what my hope was is that you could each take maybe 5 to 10 minutes, scan this QR code, take the quiz, and then we can take a little bit of time and discuss what popped up on the results for you guys. And share as much as you're comfortable with. One of the things I find interesting in these types of activities is not only sharing what your top attachment styles were and maybe some of your top characteristics, but thinking about how does some of this play into your work at times, working in the field or working with clients. Like for instance, I'll use myself as an example. I mentioned earlier that my wife teases me that I always need a cookie and I always need reassurance, right? That's a characteristic that I'm prone towards. Well, that can play into my work as well, where I always need reassurance from my boss, or I can have difficulty when a client's upset with me or things like that. So, one of the things that's good with this type of quiz is looking at how can some of these create, challenges in our work that we have to make sure we're aware of and that we're staying, strong on. So, yeah, so if everybody's willing to take a second, scan this, take the quiz, hit show results, and here in about 5 or 10 minutes, when I make sure everybody's done, we can take turns sharing if you're comfortable with it. Any questions on that? We'll answer questions around this whole thing after we're done with this exercise. So, but if anybody has any questions around taking the quiz, please let me know. Hey, Stephen, would you mind going back to taking the slideshow down and just having people's uh, screens up?
Absolutely, Doug.
And then if you could do me a favor and if you see something in the chat or see somebody raise their hand that I don't notice, please let me know. Does
Will do.
anyone need a few more minutes to complete it, or has everyone been able to complete their attachment style quiz okay? All right.
We have someone
So,
mention in the chat, Doug, that they're still working on it.
oh, great. I'll give you a couple more minutes. Maybe do me a favor, and when you're done, do like your hand up or a thumbs up so we know that you're all finished, or type it in the chat. All right, we'll give it another minute or so, and then we'll get started. We've got a little dog in my household that grunts and snorts and makes all sorts of interesting noises. So, and it insists on sleeping right next to me whenever I do a presentation. So if you hear any noises, I promise it's not coming from me. All right. Well, let's get started. First off, I don't mind sharing just to kind of break the ice. When I first took this attachment style quiz, um, first off, I was pleasantly surprised that the secure score was higher than I thought it was going to be, which I think was some of the years that I've had working on my recovery and stuff like that. Anxious and fearful were my two insecure attachment styles that correlated the most for me. Once again, I grew up in an alcoholic household, and there was also abuse that was pretty prevalent in my household. So those two definitely came up a lot for me. I did an interesting thing too. Right after I took the quiz, I decided to take it a second time and think back to where I was when I first got sober and what it would have been then. And that was an interesting way of looking at, how far I've come over the course of my life. So that may be something that you guys find interesting. I made the mistake of seeing if my spouse wanted to take it next, and be careful on that one. If you want to try to get your spouse to take this, that could go good or bad depending on the spouse. So, all right. Well, what would be helpful is if somebody would raise their hand who's willing to volunteer. Thanks, Melissa. I appreciate it. So, Melissa, we'll let you go first. So, if you could share what your 4 attachment styles were from highest to lowest and what the score for each of those was, and maybe your top 2 or 3 insecure attachment characteristics, that would be really helpful.
Okay, I don't know if I can do, I do have the characteristics. So I also come from an ACA household, of many generational, alcoholics and addicts. And I'm not a clinician, so I want to make sure that I clarify that. I have been working on attachment work for 4.5 years with a primary therapist, and it's hard work. It's like really hard work. And so that's partly why you're here today, Doug, because I wanted you.
Thank you.
And I thought it would be really helpful for people to get these kinds of quizzes. So I was fearful, avoidant, anxious, secure. Those in that order. And the fearful was 35, avoidant was 29, anxious 27, and secure 24. And then I have an exaggerated startle response. I expect the worst to happen in relationships. So that's a typical ACA kind of characteristic. Um, I disconnect, disassociate, or get confused remembering difficult childhood experiences. That's very common for severe neglect and abused children. They disassociate. It's the only way they can kind of make it through. And then I tend to alternate between being overly dependent or pulling away completely. I sort of am that black and white kind of, sometimes behavior. And then lastly, in high stress situations, I always resort to fight, flight, freeze, or fawn, being that it's CPTSD. So I hope you don't mind that I shared first. I'll
Not at
put my
all. I'm
hand
glad.
down.
Do you mind, I know you're not a clinician, Melissa, but do you mind if I ask the work that you've done over the last 4 years, besides helping yourself personally, have you seen it manifest at all in terms of your relationships, helping your relationships improve through
Yeah.
attachment?
So when I'm sort of sharing what's going on in my life, I'm able to I'm able to hear him say, "This is your blank 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 style, Melissa, coming out. Like, can we take a step back and take a look at why you're feeling this anxious attachment or fearful attachment or avoidant attachment?" And then we have to process it. I should also note that I've done EMDR along this process. So I see this nicely nested around EMDR because you're reliving a memory over and over again until you've processed it fully. And that's hard work. So,
Absolutely.
so that's me being vulnerable in today's
Thank you.
COP.
Thanks for going first, Melissa, and thank you for being vulnerable with us. And I will tell you, a lot of the therapists that I've trained to use this model are EMDR therapists, and EMDR is something that's been a huge personal benefit in my life. And also I've seen professionally how many people it helps. So yeah, I can't agree with that more. All right. Pam, you had your hand up. Are you willing to share yours?
I am willing to share mine. So I do have a history of a parent with alcohol use disorder and significant mental health conditions. Well, she's deceased now, but growing up, and I also grew up in a very abusive household. So I was very surprised by my results, that my first attachment style is actually secure with 27. Everything was pretty close though. My second attachment style was avoidant, which doesn't surprise me at all. My third was anxious. And then my fourth was fearful, and fearful was the lowest with 18. My insecure attachment characteristics don't surprise me. I feel more comfortable giving help than receiving it. That was the first one. And then I prefer relationships with things or animals instead of people, which is ironic because my whole career has been working with people and families and stuff like that. So
I'm laughing because I can relate, just so you know.
Then I have difficulty reaching out for help and do many of life's tasks alone, which is accurate, but I would kill my children if they did that. So, then it is easier for me to think things through rationally than to express myself emotionally. And finally, I take it personally when a person who is important to me makes plans with other people. Which, when I answer that question, I'm like, wow, I never realized that about myself until I answered that question. So apparently my years of therapy are helping.
That's great. That's great. Do you ever see, it sounds like you do work in the field and work directly with people at times. Do you ever see any of this stuff come up in your work, whether it's with your coworkers or supervision or your clients or anything like that?
So in my previous role, my current role is I'm a recovery friendly advisor. So I work with businesses predominantly, and I just started this role. But previously, yes, I worked for DCYF here in New Hampshire, a division of Children, Youth, and Families, and I worked for CASA of New Hampshire. So I worked a lot with families, and prior positions were client facing as well. And I did see a lot of this. Direct services is challenging. So I have a graduate certificate in community mental health with a specialization in co-occurring disorders. So it really kind of is a passion of mine, working with families with substance use disorder or mental health conditions. So when I saw the training opportunity, I'm like, oh, I'm going to do that because I've done a lot of different ones in the past. So
thank you. Well, thanks for being here, and thanks for being willing to share your attachment styles and characteristics. I really appreciate it.
thanks.
All right, is someone willing to go next?
Can share. Let me turn my video back on. So my top attachment style was anxious, and then avoidant, fearful, insecure last, sadly, but they were all very close. They were all actually within a point of each other. Um, and my top 5 attachment characteristics, they feel very accurate. It's like when you read the horoscope and it's like, how is that so accurate? But what I thought was really interesting actually is my attachment characteristic number 4. And I thought this was interesting even when I was taking the quiz, but when I lose a relationship, I might first experience separation, elation, and then become depressed. And I was just interested that that was a common enough experience that it was on this list. Because I hadn't really thought about that before, but I fully feel that, like, it's sort of okay, you've broken free of the obligations that come with a relationship and the time commitment and all of that. And it's really exciting. It's that roller coaster. And then it's a week or 2 later that the sad emotions follow. So I just thought that was interesting to see that on the quiz, because I had never really thought too much about that experience, but I guess seeing it, I was like, oh, I didn't know it was that common, that it would be something that, is commonly experienced.
Yeah, thanks for mentioning that. I appreciate that, Paul. And yeah, that's definitely one that comes up for people at times. The other thing I want to mention really quick, because you and Pam both kind of touched on this. Sometimes if your scores are really close, people can say, well, what does that mean exactly? One thing to think about is when you look at those attachment styles, are some of those attachment styles more prominent in certain areas of your life than others, right? So like if I'm at home with my kids, which attachment style might be more prominent? If I'm at work around my coworkers, which one might be more prominent? So a lot of times if those scores are close, it kind of, by looking at when do those show up in our lives, we can start to see some stuff as well, which is interesting. Thanks for going, Paul. I appreciate you sharing those with us. All right, so this is the area where we need some more people to participate. So I'm going to ask your help and ask you to raise your hand and be willing to share whatever you can. Anybody else willing to share theirs?
I'll share.
Thanks, Sarah. I appreciate you stepping in.
So I exited the link too early, so I don't know what the stuff that everyone's saying last is, but I scored a 28 on secure attachment, a 21 on anxious, a 21 on avoidance, and a 16 on fearful.
Nice. Did anything jump out to you about those scores?
It was exactly as I anticipated in the order of the things.
Nice. So it felt like it connected pretty well with how you see yourself?
Yeah, it did.
That's great. That's great. And you said that you left from the link too early and you didn't see the top characteristics?
Yeah, no, I exited the link, unfortunately, and I really don't feel like taking it again. So.
That is quite all right. We won't ask you to do that. Yeah, hopefully maybe we can show that link up again towards the end or something. And if you want to save it so that sometime in the future, if you want to take it, you can. So thanks for sharing that, Sarah. I appreciate it. Hey, really quick, do you mind if I ask, if you work in the field or work directly with clients, do you see your attachment stuff playing into you needing to be mindful of any of those areas in the work that you do?
I used to work directly with clients in the field, but I haven't in about 4 or 5 years. So
When you did work directly with them, did you have to be mindful of any of those areas?
definitely.
Nice, nice. Well, thank you once again. I appreciate you taking the risk and sharing. Anybody else willing to share theirs?
Hi, Doug. Kareen sent a message in the chat that they're willing to go.
Great. Yeah, Corinne.
Hi, I'm
Hi,
Corinne
thank you for doing this.
Yeah, no problem. Yeah, I just took it, so I think I actually find it kind of interesting. I grew up in a pretty hectic household, a lot of like parental trauma. But I wasn't surprised to see that my main style is secure. I do feel like that's congruent. I thought it was interesting though that the style number 2 was avoidant. Because I don't necessarily identify with that, but I guess I could see it like kind of like what you were talking about in certain environments where that pops up a little bit more. Um, and so like my top one attachment characteristic was it's easier for me to think things through rationally than to express myself emotionally. I really do identify with that because I tend to, I think something I learned as a kid was I tend to just kind of shut down and go within myself rather than kind of, I was a lot more, I would internalize a lot. So I can see that. It was really interesting to take and to your point from what you were talking about with the other person that was speaking about it was how we as professionals, I'm a clinician as well, I'm an LACSW, and thinking about how this can play into like counter transference and how this can play into how your attachment style might be, you know, kind of interplaying with your client's attachment style. So I found that to be interesting.
Yeah,
Yeah.
it's really interesting. You know, first off, the one attachment style that tends to surprise people the most often is avoidant attachment style, the same way that you're saying. And I think a lot of us, you know, what I consider an avoidant type of person is different than some of those characteristics that are under avoidant attachment style. And so it kind of surprises some of us, but you know, definitely that like tendency to think things through instead of feel them first. And also for a lot of us that are just have difficulty connecting and feeling safe, like asking for help or trusting other people because of childhood circumstances, that can play into it as well. So yeah, and then the other aspect that I'll touch on is every one of the 2-day certification trainings that I do around this, you know, all of the clinicians go through and do this work for themselves because, just like you said, it's so important to know how our attachment styles might interact with the clients that we're working with. If my client had a father that had a strong avoidant attachment style, I could be triggering that at times. And so, you know, being able to be aware of your own attachment styles and buttons, and also what buttons you might be pushing with your clients is important as well.
Right, absolutely. I see that being just like a totally, you know, other layer to all of this, especially with like trauma work. The whole time you've been talking about this, my mind has just kept going to trauma, 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 because how much of attachment and trauma is really just so interconnected. So I think it's also awesome that you have really high success rates with people with trauma, and I can see how this interplays a lot, which is really cool. So all really great information. Thank you so much.
Great. Thank you, Corinne. Thanks for going. All right, we've got about 5 more minutes on this part. So would a couple more people be willing to share what they came up with on their test? Thank you, Cheryl.
Sorry about that.
No problem.
Sure. Let me just pull up my list.
Thanks for sharing.
You're welcome. I found it interesting and reassuring. How's that?
That's good. I like
My
reassuring.
Yeah, my first attachment style is secure with a 31. And then
Nice.
my following three are avoidant, anxious, and fearful. And it's very interesting because I feel like the avoidant thing, as we're talking through it, I feel like the avoidant thing is, okay, I don't really want to do this. So let's think through the process and then go do it anyway.
Mhm.
Whatever that is that I'm avoiding for whatever reason. It could be a hard decision. It could be, okay, I got to go into this meeting. Or as an executive director of a program, I'm not a direct clinician, but I have to be the leader,
Mhm.
right?
Mhm.
So I find it really, this was really interesting. Thank you.
Yeah. What do you mind sharing some of the top characteristics that came up on your quiz?
Sure. So my number one was I feel more comfortable giving help than receiving it.
Mhm.
And it's easier for me to think things through rationally than to express myself emotionally. Although I'd have to say that my staff sometimes hear me and I'm having an emotional moment. And there are several of them on this call. So, I sometimes I feel upset when I'm faced with criticism or disapproval.
Yeah, that's really good. And it's good to be aware of how that can impact. I know from being a clinical director, I had a large team of people reporting to me, and I have some of those same characteristics. And it was something I had to monitor on a consistent basis. And I'll give you an example, like when somebody would disagree with me in front of a room full of people. From a leadership standpoint, that's a great thing. Like you want people to have the safety to voice that to leadership.
Yeah.
But then there's that little child button inside of me that would be like, "Ugh," and I'd have to
Yes.
like be able to breathe through it and not respond and make sure and thank them for taking the courage to do that. So it's interesting how these sort of characteristics that are ingrained in us from early on can be impacting our work even like 50 years later, you know?
I think too, sometimes it's also, okay, I need to choose which battles I'm going to fight, right?
Totally.
Because as, again, I'm bombarded with a million things all day long. So, okay, which ones are the priorities and which ones am I going to take on now? And I don't know that I'm avoiding them. I'm just trying to prioritize the list so that I can make sure that the most important tasks are completed.
Yep. And once again, I think that's where sometimes I get tripped up and people I work with this model get tripped up is what we consider avoiding isn't necessarily always what's congruent with the avoidant attachment style. They're just like characteristics that we feel comfortable with. And really the reality is for a lot of people, it's because of growing up in environments where there wasn't mutual dependency. You couldn't count on people and this and that. So it's not necessarily I avoid things as much as I don't feel comfortable like asking for help or things like that because that stuff's ingrained in me. And so it's interesting how sometimes the word avoiding can cause me at least to not see this in myself because the attachment comes from a different angle with it or something.
Sure. And I would say that my years growing up, there was some serious parental, all kinds of crap going on, just not necessarily identifiable because I don't think I paid attention to that. I just wanted to not be involved with it.
Mm-hmm. Yep. Nope. I totally get that.
Avoiding it.
It's really interesting too that they've started to look at which attachment styles lead people towards certain career choices, which is really interesting, right? Like people in the helping professions, which attachment styles are most prominent. First responders have certain attachment styles that are most prominent. So it's really interesting how some of these things we grow up in difficult environments, and it actually is conditioning and preparing us for careers that we're going to do down the road, you know, not
And
that.
you never know what you're going to choose. And then you look back on it and you say, that's really interesting that this is where I am.
Yeah.
It's very interesting.
Yeah,
For sure.
definitely. Well, thanks for being willing to share, Cheryl. I
You're
appreciate it.
welcome. You're welcome.
Corrine, you had your hand up?
Yeah, something that came to mind for me was a lot of like role reversal, especially growing up. And where have you seen that kind of fall into some of the characteristics, I wonder, and like in certain styles of that?
Yeah, you mean like being parentified at a young age and stuff like
Yes.
that? Yeah,
Because that
I
was
think
a big thing for me, and I wonder how much has played into my scores.
Yeah, I think a lot of it is falls under anxious and avoidant. Avoidant in terms of there's characteristics around or the childhood environmental factors were like asking children to be overly independent at a young age or
Mhm.
be tougher than their age warrants them being. So there's some of that. And then with anxious attachment, there's a ton of parentifying people feeling responsible for your caregiver's emotions.
Mhm.
All of those sorts of things where you're developing emotional responsibility that you shouldn't have to develop yet. And it's interesting because those two attachment styles are the most prone towards not only our type of work, but also first responders, right? So it's
Yeah.
interesting how a lot of this stuff plays into that for people. So yeah, I
Yeah.
definitely think there's a big correlation with that.
Yeah, and I can see how how that can play into the avoidance too, like particularly in the context of my scores of like it's easier to help other people than to kind of on myself because I grew up just having in that parentified type of role, like taking care of my mom and stuff like that, who had mental illness, and it was kind of yeah, that kind of struck me a little bit.
Yeah, I definitely think that that would play into
Mhm.
like an avoidant attachment style and stuff like that. So yeah, that's a really good
It
point. Thank you.
clearly led me into this profession. I was like, oh, my mom, so I'll be a therapist, sure.
Yeah. I know I don't mind sharing this with you guys. In the household I grew up with, obviously I had an alcoholic father that I mentioned that had anger issues, and I had a suicidally depressed mom.
Mhm.
And as a young kid, I had these two intense situations coming at me, and I was kind of the filter at times between the two of them. And on one hand, that's a really a difficult environment to grow up on as a kid. On the other hand, it's allowed me to be really good in the profession that I've been at times, being able to handle intense emotions
Sure.
from people
Yeah.
and help guide them through it. So, I always try to look at how we utilize negative experiences and turn them into strengths in our life. And yeah, it sounds like you've had some similar types of experiences.
Yeah,
So
that's a really good point because I remember feeling really like I'd struggle with that feeling of like, but why I hate this, but also why do I take such pride in it? Why do I take such pride in being the helper in my family? And at the same time, I'm like, I need some boundaries around that.
yeah,
And it's kind of that push pull. Yeah.
yeah, definitely. Well, good question. Thank you. All
Yeah.
right.
Thank you.
Well, does anyone else want to share their attachment style quiz? I know we also need to move on to just questions around the presentation as a whole. And does anybody have any questions around anything that I've presented today or any thoughts around anything? Thank you, Heidi. Thanks for commenting. Anybody else? Anybody have any questions or any thoughts or anything? Yes, Corinne.
I'll go again. Sorry.
Hey, no, I appreciate it. Thank you.
Um, how do you feel? I mean, I know you were saying this is a very kind of it's very I can see how it's very empowering. It's very client centered.
Mhm.
And in your experience, if you've had the experience of like if people being mandated to attend, how do you? I mean, because I can see there's some motivational interviewing aspects to it.
Definitely.
Um, have you found that in your experience, this has been a really good model for people that have been mandated?
Yeah, I think it does work really well for people that have been mandated. You know, initially when it rolled out, people had a choice what group they've chosen, but since I've been going into other organizations and branching out more, it's definitely being used in a lot of groups where people don't choose to go into it. It's just what group they go into. And definitely, I think the safety and the environment makes it better once again for engagement into the group for them. That being said, I am definitely a big believer that one size doesn't fit all when it comes to models, right? And I completely agree with you that there's times that MI is really important in terms of helping with you know, the engagement into that process. But I will say, even if people have a degree of resistance around going into it, it tends to manifest less in this than some of the other models.
Yeah, I can see that because again, it's like it's put on the client like right away from the beginning. Like and it kind of takes what I think is interesting is that it takes I feel like you're going into your attachment. You're not just going right into like, so tell me about your substance use issues. You know, like you're really, and I feel like that kind of takes away like some of the blame you're talking about and like suspends some judgment, which I can see some of that DBT playing into that too. How long is the I'm sorry if you already said it, but how long is the when you do the group, how long do you do it for?
Do you mean each specific group?
Yeah,
Or do
like
you
do you
mean,
have it kind of like with DBT, do you kind of do it in cycles where you have like kind of a 13-week or 6-week and then
yeah,
individual, or is it kind of open-ended?
it's kind of open-ended in that regard. I've seen residential clients use this curriculum for between 3 and 4 months. I've seen
Okay.
outpatient clients use this for anywhere from 6 to 12 months. So it's pretty open-ended. I've seen people do this in groups where there's you know, revolving admissions coming in the door versus closed groups where they all go through stuff together. So I really tried to design this curriculum where it's flexible and can be used in different ways.
Okay, cool.
Yeah, yeah,
Yeah.
thank you. And good point. Somebody else, Heidi, was it you that had your hand up?
Yes, it was me, and I had the same question as Corinne about like the format and how many groups, you know, it would end up being. I guess I am curious. I oversee a collegiate recovery program at the University of New Hampshire and support some alternative peer groups for youth and young adults with substance use. And you know, would like to learn more about the model, I guess, you know, what would the next steps be for somebody that was interested in learning more?
Yeah, so Stephen, before we're done today, he's going to put a slide up with my contact information
Great.
on it. Also, are you going to the conference in San Diego later this month?
I am.
I
Yes,
am
I was
present.
actually thinking when I saw Harmony,
I am
I
presenting.
worked. Oh, great.
So I'm presenting on Monday morning with the principal of Harmony Academy at that conference. So if you reach out to me, maybe we can schedule a time to get together and talk for a few minutes or have some coffee or something while we're there.
Oh, that'd be great. I don't know if you have done any work with Robin Bergeron, but I have some colleagues in Oregon as well that facilitate some alternative peer groups. So it'd be great to connect you with them as well.
Yeah, I would appreciate that. That would be
Yeah,
great. Thanks, Heidi.
awesome.
Anybody else? Oh, and one question, and Corrine kind of brought this up, but something I want to mention. One thing with this model is it really doesn't mention substance use disorder a lot in it, right? Which is kind of interesting. Like, and actually clients really appreciate that about it, that it kind of goes a layer below substance use to focus on what's feeding into these areas. There are times where it focuses on unhealthy, you know, behavioral reactions and a relapse prevention plan. But in general, this model doesn't just come right in focusing on substance use disorder. So people who are still struggling with acceptance around that stuff, this tends to do a pretty good job of dropping more into their interpersonal stuff and then diving into how it's manifested in their life, which tends to work really well. All right. Anybody else have questions? We've got a few minutes left. Any other thoughts or?
Hi, Doug. I'm Jan Thomas, and I apologize. I've been in and out of the session, so those meetings have been coming. I'm a primary care nurse and working in applied research right now, but and just dipping my fingers early into substance use, extremely interesting. The data that I did hear, again, I've bits and pieces like, wow, this is really cool stuff, exciting stuff. And I guess I look forward to, well, behavioral integration, if behavioral health and primary care, and how can we work together? And I'm assuming the principles of this are going to function also with people that have other kind of chronic
100%.
disease or chronic influences in their life, and that it's not, as you said, not just about substance use. So I'm looking forward to learning more and finding out more.
Yeah, thanks, Janet. And once again, we're going to put my contact information up in a minute. If you want to reach out, I'm happy to come to any of your organizations and do presentations. I'm NADAC accredited to provide CEUs if there's any of your organizations that can be helpful. But yeah, it definitely is interesting how foundational this model is, and it can apply to so many things.
Yeah, so many things.
Yeah,
It's cool.
it's really exciting. I've got couples therapists in Texas using this model in couples therapy, and yeah, it seems like every week there's new things that are popping up. It's like, oh, I hadn't even thought of that. So yeah, it's really fascinating.
It definitely. I'm in UNH. We're not with Heidi. We're in different big place, and but definitely I work more with nursing and health policy and primary care, but also thinking about the value we can bring to our students, and are these things that we can pull in and when, and we do some work with Dan and Carol, and so great job. Thank you. I apologize I didn't step up because I realized when I was trying to do my survey, I was answering the questions like opposite, so it came out, even though it did still come out pretty
No
well.
problem.
I did come out with attachment with that I did well, but security, but I realized you have to pay attention when you do that survey though. Don't do
No
what you do.
problem. No problem.
So
Well,
thank you.
hopefully we can be in contact later. I'd love to talk more about how to work with you possibly. So, anybody else have questions? Stephen, would it be possible to put the contact slide up for everybody? So this has my phone number and also my email address. And so feel free to reach out to me. And like I said, I'm always happy just to talk more about this model. And if you'd like me to come work with your organization specifically or do a presentation like this for your organization, yeah, I'm always happy to discuss ways to work with people. So please feel free to reach out to me.
The woman who just shared from UNH, New Hampshire TAC, we have some experience in that integration of behavioral health and primary care. So if you need to get in touch, Stephen will also put up our website at the end. And yeah, we're right in your backyard. So if that's an interest for her, she can follow up with us.
Thanks, Melissa. That's great.
And Doug, great job today. Thanks so much for being here.
Thanks, Melissa. Yeah, thank all of you for taking time and allowing me to present. And once again, any questions or things, don't hesitate to reach out. I'm always happy. And also any suggestions or thoughts, I'm always very open to feedback on how to continue to improve this. So please don't hesitate to reach out to me for any of that. And Melissa, thanks again for the opportunity.
Absolutely. We're excited that we got you from Oregon. So yeah, we're super excited. Stephen.
Doug, just very quickly, Corinne has their hand raised.
Oh yeah, Corinne, go ahead.
Yeah, sorry. I was wondering, on your website, can we find where those other forms are that you were showing in the presentation of like the other kind of quizzes and all of
Yeah.
those that like the tools that we can use to maybe start doing this with clients?
Yeah, so what I'm doing, that's the first quiz is the only one that I've got public access available to. The
Okay.
rest of the forms, what I do is people reach out to me and I do certification trainings to make sure
Okay.
they know how to use the curriculum, and then they can get some of those forms for me and stuff like that. So if
Okay,
that's something you're
awesome.
interested in, please reach out. I absolutely can talk with you about how to make that work.
And
Okay, so
Corinne, if you think that this might be like a suitable 2-day training next year that you think clinicians would be interested in, let me know that, because that's part of my role, is finding those gems to bring to the clinical world.
oh yeah, awesome. Yeah, because I'm in primary care. I'm at Lamprey Healthcare.
Oh, Lamprey, I was with Goodwin
Yeah,
for
they
7
do.
years. Yeah.
Yeah, we do the integrated behavioral health care, which is
Yep.
awesome. I love this model, and yeah, I think this could just play in so nicely. So yeah, that would be great. So thank you,
Yeah.
Melissa. I appreciate that.
Sure.
Yeah, and Melissa, I know I've mentioned this before, but I'd love to come back and do a longer certification training
Yeah.
for anyone who's interested.
Yeah, so we're booked into January for next year, but we are looking for day-long, 2-day-long trainings that clinicians would not need to travel for. It makes a big difference bringing that resource to New Hampshire. It's just really about getting the numbers.
Yeah,
Yeah,
that'd
that's
be great.
huge. Yeah, come on over to New Hampshire, Doug.
I'd love to. I'd love to have an excuse to go visit. I'm actually coming out to New York in October, so but yeah, I'd love to come out to New Hampshire.
Nice. Well, thank you.
Yeah, thank you.
Wonderful. Okay, I think it is time to wrap this up. Thank you so much, Doug. Thank you for taking the time to be with us. Thank you for sharing your experience with us. We do truly appreciate it. And thank you to all of you who've been able to participate today for enriching this training. So before we finish, I'll just share a couple of things. I'm going to pop 2 links here for you in the chat. The first one is to our website, nhtac.org, where you can view the recording and the slides of this COP, go back and watch previous COPs, sign up for future COPs. Don't forget to check in regularly, and you'll stay in touch. So there's the website address in the chat. And lastly, we truly value your feedback, and I've popped an evaluation link in the chat for you as well. We'd love it if you would just take a couple of minutes to share your opinion with us. Anything that can help us improve is truly appreciated. So once again, thank you, Doug. Thank you to all of you. Have a wonderful rest of your week and weekend, and we look forward to seeing you again next time.
Thank you.
Thank you. Thanks for your help, Stephen. Thanks, Paul.